Hello, I am Dr. Gus Lividitis, a prosthodontist practicing in Baltimore, Maryland. I am also co-developer of the Maryland Bridge technique along with Dr. Van Thompson at the University of Maryland School of Dentistry. This segment describes an alternate design to the original posterior etched metal retainer and describes variations to manage the range of conditions affecting posterior teeth. The term retainer is used as the general term for the single tooth component. Just as bonded composite resin restorations changed cavity preparation and retention features of amalgam and cemented inlay restorations, the Maryland technique significantly changes tooth preparation, restoration design, and retention from conventional crown and bridge procedures. An experienced restorative dentist learns what comprises a retentive configuration for a traditional crown or inlay preparation: near parallel walls, prep length or lack of, adequate ferrule, minimum frictional retention, and type of cementation. When utilizing the Maryland technique, one will learn what comprises a retentive configuration based on bonding to adequate surface enamel, to internal enamel, and to an etched metal surface. These three images illustrate the attachment mechanism of the Maryland technique. It consists of etched external or internal enamel and an etched metal surface. I prefer the term differential dissolution of surfaces resulting in a micromechanical pattern. All three surfaces provide two levels of retention. Level 1 consists of larger ridges and crevices on all three surfaces, and level 2 includes micro retention within those larger ridges and crevices. A liquid unfilled resin is applied first to engage both levels of retention, followed immediately with a resin cement and insertion of the prosthesis before either resin polymerizes. This system, coupled with sufficient interface area of metal and enamel, provides effective long-term micromechanical retention for a prosthesis. Let us compare the original etched metal posterior retainer with the alternate retainer. The original etched metal posterior retainer includes a proximal segment which provides a connection for pontics and significant bonding surface. A lingual segment, sometimes referred to as a lingual wing, also provides significant bonding interface. An occlusal rest, which provides a vertical stop for seating the retainer and may help resist occlusal forces. While others incorporated proximal grooves, ledges, and depressions on anterior teeth for Maryland bridges, such extra components are not needed for posterior bridges. However, design and tooth modifications for existing restorations, including composites, amalgams, or cemented inlays, will be described for etched metal retainers. The following categories of abutment teeth will be described for etched metal retainers: intact posterior teeth with a new retainer design, tilted intact teeth with partial or little occlusion, caries or restored teeth with shallow lesions or small restorations, caries or restored teeth with deep dentin involvement. In the very beginning, existing restorations were merely circumvented or excluded the teeth as candidates for etched metal retainers. And an alternate inlay-onlay posterior retainer is introduced and preferred by this presenter to include a proximal segment similar to the original retainer, and an occlusal segment which replaces the lingual wing and serves as the occlusal rest. First, let us discuss the role of metal in the Maryland bridge technique. It provides strength for the connection to the pontic segment. It provides strength between the occlusal and proximal segments, which is a stress area. And it provides micromechanical interface for bonding. The metal enables fusion of porcelain for reducing metal thickness to improve reversibility of treatment, to be discussed later, for improved aesthetics, but still less aesthetic than all porcelain or zirconia restorations. The tooth surface categories for bonding, and by the way, the term bonding refers to both the liquid unfilled resin and the composite resin, cement, to enamel. Bonding may be to etched surface enamel only, an acceptable solution. To etched internal enamel walls and pulpal wall or floor of enamel, also very acceptable with or without extension of the framework into the cavity preparation. Or internal lateral walls of enamel with fresh composite base placed during the bridge insertion visit, or less desirable to recent composite base, or least desirable old composite or amalgam base. In viewing the alternate posterior retainer components, the occlusal segment serves as a vertical stop replacing the original occlusal rest, contributes significant bond interface. It may restore occlusion with the opposing tooth, or it may restore caries or replace an occlusal restoration. The occlusal segment for an intact tooth in optimal occlusion includes a shallow inlay preparation for optimal metal thickness. Should extend from the proximal segment to the opposite marginal ridge. It should extend halfway from central groove to cusp tips, both facially and lingually. And by the way, near parallel retentive walls are not necessary. A curved bonding surface is preservative and acceptable. Furthermore, the occlusal segment for an intact tooth should include a prep depth of 1 millimeter for an all-metal bonded interface, or as low as 0.5 millimeter in limited or tight areas. Should include a prep depth of 1.5 millimeters when adding fused porcelain. Include fused porcelain to reduce metal thickness to 0.3 of a millimeter, except at the marginal ridge next to the proximal segment. And always strive to maintain enamel cavity floor. The proximal segment with divergent or slightly divergent or near parallel internal walls. Confirm the enamel walls are consistent with the path of insertion. Block out the deeper dentinal walls with composite. Extend the framework into proximal inlay segment and extend beyond as in the proximal segment for original retainers. The entire proximal segment should be consistent with the path of insertion. When confronting convergent cavity walls on proximal or occlusal segments, if slightly convergent, trim only the enamel portion of the walls consistent with the path of insertion. If severely convergent, do not extend framework into the cavity prep. Trim the entire proximal segment for a path of insertion. And then if you have shallow dentin, the bridge insertion resin will restore the cavity. If deep dentin, restore with a composite base to the dental enamel junction. An onlay segment for a tilted tooth with partial occlusion. The general guideline is to preserve enamel whenever possible. Trim as needed for adequate enamel to metal interface as little as 0.5 millimeter. Trim as needed for fused porcelain, again 1.5 millimeters for porcelain, including 0.3 of that 1.5 millimeters for metal thickness. Trim as needed for a common path of insertion. Extend for additional bonding interface with existing clearance, which you really don't need to do any trimming as you extend on a lingual surface. Let us consider the low risk for caries with intact etched metal resin bonded retainers due to an insoluble resin bond, the cement, which lasts for 3 to 4 decades as demonstrated by anterior bridges. Inlay etching and bonding of enamel extends beyond the framework. In other words, when you're inserting the bridge, you're probably etching beyond the outline of the framework, and you will be bonding to that surface with a film of resin. And by the way, inlays typically include supragingival margins. Now the areas beyond the restoration, way beyond the restoration, involve a normal risk for caries. There is an increased risk for caries with a detached retainer. Caries may occur rapidly despite the enamel layer. The tooth may also be displaced due to food impaction. Partially detached inlay bridges are irreparable. Do not try to tap off a resin-bonded inlay bridge. However, if patients are very aware of a detached etched metal retainer, they can feel the edge of the retainer or probably the edge of the resin cement. And you should deal with this problem promptly. Now, in sending it to the laboratory, you want to draw the outline of the restoration on the cast when possible and provide precise instructions to the laboratory. Request alloy known to be reliable for micromechanical retention. Request application of porcelain instead of thick metal retainers, and insist on a proven etching system for the selected alloy. Now let's review some actual restorations. The standard retainer on premolar and an etched metal inlay on the molar. Note the proximal preparation on the molar and the retainer extension beyond cavity on the lingual side of the tooth. The restoration has been intact for over 34 years. One of the early applications, standard Maryland retainer on the premolar and an inlay onlay on the molar, and the bridge continues intact for 39 plus years. At the time, the amalgam was trimmed to expose internal enamel, but was not removed completely. Currently, the amalgam would be removed completely. Dentinal floor of the cavity and any undercut dentinal walls would be restored with a composite base. The enamel walls would be modified for a path of insertion. The occlusal portion, not an inclusion, was and would be restored with etched metal and fused porcelain. The inlay on this preparation could detach mesially, facially, and occlusally if cemented conventionally. Moderate perimeter enamel, a more occlusal extension for enamel to metal bonding, has retained this restoration for over 34 years with a normal functional load. A dual inlay bridge with porcelain is ideal design. Note the extension beyond the cavity preparations. Only a 16.5-year follow-up was available due to the death of the patient. Although this was an early bridge in the investigation, the restoration with composite of the existing cavity up to the DEJ and modifying only the enamel walls for a path of insertion applied to the more recent guidelines. The 4-unit bridge has been intact for over 35 years. The combination of a standard anterior retainer with an etched metal inlay supports micromechanical retention with a variety of retainers. The single second molar inlay is non-retentive by conventional inlay standards, but based on perimeter enamel and extended occlusal enamel coverage has allowed these restorations to survive for over 35 years. The current application of composite up to the DEJ has not been accomplished to the current guidelines, but some blockout of deep undercuts was executed. The amalgam was removed completely and a thin composite base was placed. This restoration is not long for longevity since the patient was seen once for recall and died a few years later. The investigative point to be made is that I would currently include porcelain on both inlays. It would be extremely difficult to remove those inlays. Consider the following. Caries will not likely occur. If it does, it would be treated directly without removing the inlay. Endo access would be considerably more difficult. If either tooth was used as a crown abutment for a bridge, it would be easier to prep around the tooth with either inlay intact rather than trying to remove the inlay. This molar inlay preparation was restored with composite approximately up to the DE junction according to my current objectives. The restoration remains intact for over 38 years. This patient also had a bridge with a standard posterior retainer on the premolar and an onlay retainer which continues to be intact, last confirmed for almost 37 years. Anterior etched metal bridges have shown to be effective for over 30 years with minimal but highly desirable wraparound extension. Posterior inlays include wraparound and opposing internal walls, which provide superior or even excessive resistance to dislodgement. Etched metal resin-bonded inlays cannot be detached without high risk of fracture of the tooth. Restorations should be reasonably retrievable without compromise of tooth. Caries in prior restorations may affect the dental pulp, but etched metal retainer inlays never threaten pulp vitality. They are designed to extend no further than the dentino-enamel junction. Bridge margins are typically supergingival unless caries or existing restorations force further extension. Etching of enamel is well established. Effective etching of metal remains to be universally established. Etched metal inlays may be the most reliable prosthesis in restorative dentistry. Take a moment to review important disclaiming comments.